Hello, and welcome to Scrub In with Surgical Directions. My name is Kristen Conway, and I will be the moderator for our discussion today. We're excited to talk to you today about our partner, Sarah Bush Lincoln. They are located in Mattoon, Illinois, and they are a level 2 trauma center with 8 main ORs, and they had an state-of-the-art expansion into another 4-room ASC. I'm going to introduce Greg Regani, our VP of the East Coast, so that he can tell you about the executives that we'll be discussing the partnership with today, both the VP of Surgical Services and the Chief Financial Officer and VP of Finance.
Absolutely. So my name is Greg Regani. I met Dennis Pluard, the Chief Financial Officer, and Colt Guthridge, Vice President of Surgical Services. It was approximately a year ago. And through conversations with the two of them, they were struggling in some areas, although pretty high performing location, they still had issues with some culture, with some revenue generation post-COVID, and we're looking for a little bit of help. So that's how I met the two of them. And from there, we went ahead and established diagnostic assessment. Post-diagnostic assessment, we moved into an implementation for 6 months, and we finalized our engagement in July.
Greg, thank you so much. So today we're going to talk about, first of all, what the problems were and the reason that Colt and Dennis chose Surgical Directions as a partner. Dennis, from your perspective, what did Sarah Bush Lincoln need help working on?
Sarah Bush Lincoln, over the last few years, albeit a good problem, we've had substantial growth at Sarah Bush Lincoln. For example, our net revenues at Sarah Bush have probably doubled in the last 6 to 7 years. In the surgical area, we've gone from 6,600 surgical procedures to almost 9,600 in a matter of 3 years. We made a substantial investment into an outpatient surgery center that's on our campus. So we expanded from 8 OR rooms to actually 12. The outpatient center, if you will, was drastically underutilized. A second problem we had was that on many instances, our prior authorization process was failing us. We were doing procedures that we did not have the full authorization from the payers. Lastly, we had a PAT department that, although they were doing the screenings, I don't believe that they were generating any way of the charges, any amount of charges for the services being provided. And so from the financial end, we had a substantial amount of improvement that we could do.
And Colt, from your perspective, what were the reasons that you wanted to partner with Surgical Directions?
Dennis mentioned the substantial growth that we've undertaken over the past several years, and he did mention the surgery center. We built that 3 years ago. Tremendous facility, state of the art, but it was very heavily underutilized by our surgeons. And so we recognized that there was a need to engage a third party to help us with our block management. And moving surgeons block is a very tricky endeavor, and engaging a third party who had experience and supporting that was very important to me. The other thing that we encountered is we had culture issues. Staff were dissatisfied because surgeons, their case times did not reflect the true amount of time it took them to perform a case, causing us to have surgeries that were going late into the evening. Staff were having to stay over, and that was a tremendous dissatisfier for our staff members. So we needed assistance in right-sizing those case times so that we could fully utilize our blocks, but within the time that is allotted to those surgeons. Also, I've been in this role about 2 years, so we started the Surgical Directions engagement about a year into that. I recognized that I had a lot to learn, and I wanted to engage a consultant to accelerate my growth and my learning, and Surgical Directions seemed like a perfect fit. In conjunction with that, I had a lot of new leaders in their positions, in particular sterile processing. My leader in periop expanded her role into the intraoperative setting as well. And I wanted a third party to come in and assist them in their development as well. So for those reasons, we sought to engage a consultant, and we arrived at Surgical Directions.
Thank you both. I'm going to take a moment to turn it over to the Surgical Directions team. When you first got on site and did the assessment, can you give your perspective of what problems you were going to try and help the team at Sarah Bush Lincoln improve?
This is Tom Blasco. I was the physician assigned to Sarah Bush Lincoln. I also happen to be the founder of Surgical Directions. It was a pleasant surprise walking into Sarah Bush Lincoln about a year ago. There were issues with poor allocation of surgeon access to the two facilities. One facility, the main operating room, was literally busting at the seams. And as Colt suggested, there was a lot of stacking of cases into the night, which created a lot of unhappiness and culture issues within the staff and turnover. They also had a brand new anesthesia group that just walked in the door. It was hired and employed by Sarah Bush Lincoln. Had a lot of opportunity with them to basically get them started in the right foot. And then we had a state-of-the-art outpatient surgery facility that was underutilized, and surgeons were somewhat resistant to moving some of their outpatient cases to that. Nursing leadership was a little bit inexperienced, but they were very dedicated to pulling off a significant organizational transformation. We had a dedicated administration that very much supported Surgical Directions. That's key in any kind of successful organizational transformation, because resistance and frustrations and pushback literally always occurs when you want to bring about a realistic and an appropriate organizational transformation. But the administration supported us and the leadership and the management and the frontline staff throughout this entire organization. I can't stress enough how important it is for the administration to basically support this significant effort.
So walking into Sarah Bush, again, they were a very high functioning organization as far as understanding change management and the drive for change. So there was, again, some interpersonal things that we had to work through with some of the inexperienced leaders, and the PAT, the pre-surgical testing department, was falling behind on getting to their patients. So it was critical that we addressed that when we got on board there. And then just preparing for cases. You know, we'll talk a little bit probably in a little bit about a collaborative daily review. This is a process where you review your cases out several days in advance to find any of those hiccups that's going to either cancel a case, delay a case, or you don't have the equipment that you need for a patient, and then you have to backtrack and figure out what you can use. So again, patient safety was at the utmost concern for this group when we came in, and it continued to be through our entire engagement.
And Kate, if you can speak to the data analytics part of this, because one of the things that really drove the cultural change was having data, physician scorecards, understanding the efficiencies within the OR, understanding turnover times, first time on time starts. Kate, can you elaborate on that a little bit?
Yeah, sure. So to be transparent, I was not the business resource on the assessment, but I can speak a little bit to what we were seeing. So whenever we start engagements, whether that be an assessment or an implementation, we do ask our client to kind of give us a push of data from their EMR, whatever one that may be. And through that, we can put that into our data analytics platform. And through the assessment, we found just what Dr. Blasco and Colt and Dennis were saying in terms of the operating rooms were not properly being utilized. Again, there was way too much volume in the main OR and not enough in the surgery center. So in the assessment, we knew that there would need to be some kind of shuffling around, and we planned on using our Merlin platform and all of its components in order to help Sarah Bush Lincoln maximize their operating room as well as their entire perioperative services.
Thank you all. So the next piece that we're going to talk about is what solutions were put into place that made the greatest impact, from case costing to block management, as well as patient safety, what were the things that really moved the needle? I'm going to kick it off with Dennis and Colt, and then if everyone could give their opinion, that would be great. Thank you so much.
From my perspective, there's been a long history of the surgical suite, surgical services at Sarah Bush not being optimized. I've been at Sarah Bush for 19 years in the executive role, and I could tell you during that 19 years, I would always hear about our anesthesia and about inefficiencies in the OR. I think we've done a great job curing that. The three areas that I think were pivotal from my perspective, number one was the prior authorization, looking at the cases at least 3 days before surgery. Implementing that process has substantially lowered the amount of denials that we are going to have. Routinely, I would get calls. We have a patient down in OR. We did not get the pre-authorization. The family's here. Should we do the surgery? Obviously, we were going to. I haven't had that call now since we've implemented that. Second of all, I talked about anesthesia. We made a major investment in our anesthesia services, but integrating the anesthesia services truly within the OR, I think has been huge for us. With the help of surgical directions, knowing exactly how they fit into the OR, what their role is. Lastly, having the surgical executive team, having that chaired and attended by the surgeons, having the surgeons there supporting the decisions that are being made and the changes. I think those three things were huge in the success of this program.
Yeah, to piggyback on what Dennis stated about the Surgical Services Executive Committee, that is a committee that is chaired by one of our general surgeons, Dr. Bierman, as well as Dr. Beal, our chief anesthesiologist. I will say I was admittedly reluctant when Surgical Directions presented the formation of an SSEC that had decision-making authority. Historically, my experience had been that surgeons operate a lot out of self-interest, but I was pleasantly surprised. I think Surgical Directions did a great job setting up the foundation for that committee, as well as fostering the growth of the surgeons within it. And the output of that committee has truly been remarkable. We took a hard look at the block allocation by surgeons, redesigned that completely. We now have one of our highest volume surgeons, one of our highest volume orthopedic surgeons who previously wasn't utilizing our surgery center. He is now out there, which has helped our volumes. But that group, the surgeons have taken ownership, they're engaged, they're looking at things from an organizational perspective, and it's truly been fantastic. And it's not just comprised of surgeons. I have my nursing leaders there, as well as representatives from our practice management division that oversee the clinics and administrators. So we have our CEO regularly attends, Dennis regularly attends, our chief medical officer regularly attends. It is truly an important committee, and it has been fantastic for our organization and our continued growth. Dennis also mentioned the collaborative daily review. That is a multidisciplinary meeting that occurs every day that includes nursing leadership, charge nurses, anesthesia, pre-anesthesia testing, and prior authorization. And we're looking at a week's worth of cases every day, identifying opportunities, as Trish mentioned, for equipment, any challenges with patient comorbidities that could require increased levels of care that we can kind of head off at the pass. Dennis mentioned the prior auth. That's been huge in identifying those in advance. So those two have been transformative for our organization, and they very quickly became hardwired in our processes and part of who we are as a division. Surgical Directions also completely revamped our pre-anesthesia testing department. We do a lot of pre-anesthesia testing phone calls. Previously, those patients were called just out of the blue, and patients were unable to prepare and think about what their medical history is, what medications they're on, and it was resulting in gaps in that documentation. We've introduced scheduled calls for those individuals, as well as engaging our anesthesia department like we've never done before in the pre-anesthesia testing clinic to develop protocols that the nurses can utilize to do additional testing of those patients preoperatively to identify issues so we can ensure that those patients are optimized before they start. Surgical Directions also provided us with a sterile processing expert. We had a very new leader that did not have a lot of sterile processing experience, but she had all of the potential in the world. And the Surgical Directions consultant that came in and worked with her hand in hand for several months truly accelerated her growth and helped us refine our processes. Historically, we did not have a good handle on how many contaminations that we were seeing come out of sterile processing. We were entering safety events in our safety event management tool, but we did not have a real good hardwired process. Surgical Directions helped us create a process where those are effectively getting captured every time they occur, so we can identify what patient was involved, what individual in sterile processing was involved, so we could do targeted education to help reduce contaminations in the future. That was huge. And then two other things I wanted to mention: Olympic scheduling. We talked earlier about case times running over, leading to staff burnout, staff frustration. By adopting Olympic scheduling, where we look at the past 10 cases for that particular surgeon, for that particular procedure, taking an average of that so that we have an accurate scheduled time for that case so that we can be more efficient and more effective in the OR. And then finally, as Kate mentioned, Merlin, that system has been so helpful to us. We had the raw data, we had some dashboards, but we truly didn't have a good understanding of what our utilization of the main OR and the surgery center were. We had anecdotal evidence, we had our perception, but truly to have that data in front of us so we could see the improvement, opportunities for improvement, not only in the utilization of our ORs, but the surgeon's utilization of their block, as well as the heat map, which we frequently reference to see if we are being effective and operating within the confines of those blocks. So I could probably talk all day about the different things that we benefited from our Surgical Directions engagement, but I'll stop there.
Well, from a generalized approach, we've learned over decades that the key body within any kind of meaningful organizational transformation is an executive body that's made up of surgeons, anesthesia leadership, nursing leadership, and especially senior hospital administration. We sometimes call it the Surgical Service Executive Committee. It's owned by the administration. It's not a medical staff committee, and it's in charge of operations. The key here is that it brings accountability. This is important, accountability to organizational transformation. For example, you have Merlin. It's given you a lot of data, and it's beginning to suggest that there's some changes that need to occur. Let's say cancellations, on-time starts, turnover times. Merlin can follow and trend this data, but it takes this group with leadership, responsibility, and sponsorship of the change to actually bring about an accountable change. A key in any endeavor we experience with our clients is the leadership body. Colt defined a number of areas that the leadership body had authority and sponsorship with. That includes preoperative preparation. A key here, and Trisha's going to talk a lot more about this, is that we've learned over the years that one of the major issues within the American hospital system is a non-timely preparation and scheduling of the patient. In other words, elective patients are scheduled within a few days of their actual surgery. We've learned over the years that working with the Surgical Service Executive Committee, we call it the 3-day rule, and Trisha's going to talk a little bit more about this, but we basically expect elective cases to be completely ready for surgery. That includes pre-admission testing and patient optimization, financial counseling and pre-authorization, and any scheduling issues that have to be addressed early. This is addressed by insisting and holding people accountable to at least 3 days prior to surgery. It sounds simple, it's sometimes hard to pull off. They did that very well at Sarah Bush Lincoln. So it's leadership, which is the Surgical Service Executive Committee empowered by a proactive and progressive administration. Then it's management, daily operational management, which includes the collaborative daily review and managing the schedule on a daily basis proactively to optimize patient access, to minimize stacking of cases at night, and to really optimize patient care. And then finally is process. And that process is everything from the time that surgeon picks up the phone to schedule that case to the time that the patient's discharged from the hospital. So it's a 3-layer approach. They did it beautifully.
So the 3-day rule is, again, making sure that all those patients are seen and cleared for surgery that 3 days out. If it's not, then there's a call to the surgeon's office. And this is where things get a little bit tricky and a little bit uncomfortable, is when we're calling an office to say, we might have to postpone or delay your surgery because we don't have X, Y, and Z. I think what was key for this to go much smoother in this organization was right up front, we included the clinic staff in our performance improvement teams. We had their feedback. We had their input on the changes we were making. We held 2 town hall meetings so that they weren't in the dark, so that as they heard things trickling from the surgeons, they had a better understanding of what we were trying to accomplish. And I think that was a really big key point with this organization, was having that support from the clinic staff and the clinic leadership, as well as the hospital leadership. So when I say clinic, that's the surgeon's offices and their processes, because any process that we're going to change may impact someone else downstream. And I think the fact that we recognized that and included them in some of the discussions really helped our patients be prepared better. The pre-anesthesia testing process is actually starting in the physician's offices. They're making sure that the pre-admission testing department has all the information they need to effectively prepare their patients for surgery. We also, again, as Colt mentioned, we started scheduling appointments for the pre-admission testing phone call, the screening call to see if those patients needed to come in to see an advanced practice provider or a nurse on site before their surgery. Patients are very, very different, and they look very different on paper than what they look like in person or on the phone. So as Colt alluded to, they were just cold calling patients to say, hey, we need to get some information. And sometimes patients, there was one particular patient that I observed was in the grocery line. We realized that that is not the best way to prepare patients. So I think a big transformation in that department was actually scheduling the patients for their appointment, letting them know what they needed for that call, their medications, their doctor's phone numbers, clinics they may have been to for outside testing. So having that information improved the productivity in the PAT department, because they weren't calling people multiple times. And when they did call people, they were ready for those appointments. So we were able to increase productivity that way as well. Again, another big thing for that organization was the frontline staff willingness and desire for change. And that's key too when we go in for transformation. We're making a lot of decisions for people that are doing work. So having the senior leadership as well as the frontline staff involved in these discussions, this planning, piloting something, if it doesn't work, realizing we can go back and regroup and roll something else out. This team was very engaged.
One of the things that's very interesting, especially with Sarah Bush Lincoln, is that, and Dennis can comment on this, is that the value increase that we added to surgical services with increased productivity, the lack of cancellations, the lack of delays, moving cases to the right area in the right facility at the right time, probably had an almost immediate impact on the value of your services and actually the bottom line.
Oh, absolutely. We're still in the first quarter post the engagement, but I can tell you one of the things that I was very impressed with was that we set up specific goals. right in the beginning of the engagement. And like I said, we're still in the first quarter, but I'm very optimistic when we measure those after the first quarter that we will have less overtime. I believe our cost per case will come down. I think we are much more efficient. And lastly, I believe the amount of denials that we're going to see on those cases is going to be substantially reduced. When you add all those up, yes, that is significant impact on our bottom line. With hospitals right now, operations at any hospital, the bottom line is being tested. And so being able to improve that is huge.
And I'm just going to say, from my perspective, having Colt and Dennis and Kim Uphoff, the CEO, as engaged as they were through this project, it would have never been as successful as it is without their support, enthusiastically support. I mean, the SSCC meeting starts incredibly early in the morning, and the executive team was there every week that I was there, and it says a lot. And the people who work in that facility see that. They recognize that their leaders are taking part. Their leaders are making their own sacrifices to be there and to make sure that everybody understands that we're all on the same page, and we're all in this together, and we're striving for success. So kudos to you two and to Kim, because without your engagement, we wouldn't be here today. We wouldn't be having this conversation.
One of the things that Dennis and Kim, the CEO of the hospital, basically asked us to do was to risk share on this implementation. And satisfying the risk standards or the KPIs was negotiated between the hospital and Surgical Directions, and they were all very reasonable, and they were doable. Surgical Directions has enough experience that we can put ourselves at risk and share risk with our clients, and understanding that we can generally meet or exceed these risk KPIs. So it was gratifying to see not only the success that the Sarah Bush Lincoln actually achieved, but that all the risk KPIs were achieved or even exceeded, or will be exceeded.
I will tell you, I remember sitting with our CEO, Kim, and when we were developing both the risk side of the equation and the reward side, we were debating, do we want to do this? And I remember sitting with Kim, specifically saying to her, if we accomplish this in partnership with Surgical Directions, we will be more than happy to write that check. And we will. That's tough for a CFO to say, but I can tell you, absolutely. Getting success there, we're more than happy. It's been great.
Great. And Dennis, I remember you had that same conversation with me. Hey, you guys do what you're expected to do, and we're happy to pay you appropriately. So thank you for that.
Absolutely.
Well, Tom, you jumped in on the results side, so thank you so much for making that segue. Are there any other results, although financial results today in today's environment are critical to both patient access, surgeon access, and hospital performance? Are there any other results that came from this that you would like to discuss?
Just one, and this is from a 30,000 foot level. Seeing some of the physician leaders kind of transition from almost what's in it for me to an administrative what's in it for the institution. I had not seen that before, at least here. That to me said a lot. There were truly physicians in the room, leaders in the room that said, okay, wait a minute, we're looking at this for what's best for Sarah Bush. And there was some times where they did things that I don't think they normally would have done. Maybe that was because they were in a collaborative team effort with their peers, but that to me was telltale.
Yeah, I think we're seeing so many benefits. I'll start at the beginning of the process with PAT. When we have those calls with those patients, they're prepared, meaning that that time spent with them is much more productive for us. We're getting a much better picture of that patient's current state. And we take that to the CDR. And so we're getting a full report out of what is truly going on with these patients and what concerns they have that we can take back to the surgeon's office and say, hey, we have these concerns. Do we need to pause and make sure that they're better prepared for surgery so they have a successful outcome? From a volume perspective, I'm comparing the first 3 months of the new fiscal year to last year. we've done 71 more surgeries than we did the previous year over that same time frame. 90 of those are at our surgery center. So we're seeing that migration that we wanted to see to our surgery center. Surgical case minutes at our surgery center have gone up over 8,000 minutes. Now, we did see a decline in how many cases we did at the main OR, 19. But I think the silver lining there is we did over 6,000 more case minutes in the main OR. What that tells me is we've taken some of those ambulatory procedures that we were doing at the main OR and moving those to the surgery center. And so that does allow for more case volume at the main OR, and those cases are appropriate for that venue. So really happy about that. Staff satisfaction is better than it's been in the past 2 years. They're getting out on time. And that's huge. We saw a significant amount of turnover, or we were having a significant amount of turnover when I first started this role. We're seeing greatly improved staff retention, staff satisfaction. So those are the main takeaways that I've seen. And we just, as Greg mentioned, we just wrapped up this engagement in July, but to see that change that quickly post-engagement is really gratifying.
Just going back to the data analytics component of the engagement, it's really important that we have the appropriate data going into all of our meetings, particularly into SSEC. Physicians, probably more specifically surgeons, are incredibly data-driven people. They want to see, what are my numbers? They want to know how we got to those numbers. So I think the way that we were able to utilize Merlin and show each surgeon their report card, show the usage of the main OR versus the surgery center OR, it really helped them get a deeper understanding into why we needed to change around either where surgeons were operating or potentially their block, etc. And so I think that was a really important component just for surgeons and anesthesiologists and everyone in the SSEC to understand why these changes were necessary, and almost make it a little bit more quantitative as opposed to qualitative of, oh, this surgery goes over, this surgeon is always keeping his staff late, etc. And I think, as Colt said, this really rolls into the results of making sure the operating room is right sized, the cases are the appropriate length so staff can go home at the appropriate time, et cetera, and continuing to utilize Merlin to make sure that Sarah Bush is on the right path. Just checking in, hey, is our utilization appropriate in the main OR versus surgery center? And just keeping up with that to ensure that there's the correct balance within the two facilities.
And as we would present this data in SSEC, when they can see it in a format that is built for surgeons' understanding and surgeons' digestion of the information, it's such a great tool for that aspect of, well, I know I use this. Well, but here, we're going to look at the exact data that comes out of your EMR to help you understand why you're really not at 100% utilization of your time.
The key that we strive as consultants when we walk into a hospital and begin to look at procedural services is to really empower this leadership group, especially the surgeons. And most of in fact, all of our SSECs are dominated by surgeon representatives. So if we have, I think we have like a 15 membership SSEC at Sarah Bush Lincoln, more than half those members are surgeons. They start to discuss the issues. You give them great data to begin to understand where their institution sits and what they need to do. And you start to get meaningful discussion and meaningful decisions that actually improve operations from a quality, productivity, efficiency perspective. In other words, it improves value. 80% of all surgeries now in the United States can be done in outpatient facilities. Like most hospitals, much of their inpatient patient care could be moved to outpatient areas. And so, and it took discussion with surgeons, it took discussions with their offices to begin to understand that moving to a very efficient almost freestanding HOPD that is attached to Sarah Bush Lincoln would actually be better for them and their patients. And so as they begin, and I told this to both Colt and to Dennis, you will begin to see as we begin to change the direction of the battleship of resistance towards patient movement and optimization of patient care, you will begin to see it accelerate in the right direction as people begin to understand that their patients are doing better, their service is better, their efficiency is better, and the system works.
I'd like to thank all of you. This discussion has been an absolute pleasure. For those of you joining us online, thank you for joining Scrub In with Surgical Directions. We look forward to hosting you again. And a special thank you to our executive guests, Colt and Dennis with Sarah Bush Lincoln. Have a wonderful day.